Hi, this is the second video on Paramyxovirus, and here we will be learning mainly about Parainfluenza virus and respiratory syncytial virus, two commonly causing viral infections affecting respiratory tract. Let's begin with Parainfluenza virus and their characteristic features. Now there are four types of para-influenza virus have been identified so far. So we have classified them as para-influenza virus 1, para-influenza virus type 2, para-influenza virus type 3, and para-influenza type 4. So let's learn about each of them in detail. Let's begin with para-influenza virus type 1. So the first to be discovered was the Sendai virus. Sendai virus comes under parainfluenza virus type 1, which happened in Japan around in 1950s. This has been since identified as a widespread natural parasite of mice causing inapparent infections. Sendai virus antibodies were prevalent in humans throughout the world. So it's been first identified in mice, but their antibodies are also seen in humans. So that means the virus infection has also affected human body. The Sendai virus is different from other parainfluenza virus in many aspects. For example, they can grow readily in eggs. Which can readily in the eggs means embryonic eggs, especially in the allantoic cavity fluid. So it has some slight variations from other parainfluenza type 1 viruses. So let's talk about parainfluenza virus type 2. This was originally isolated in 1955 from children with acute laryngotracheobronchitis, which is commonly known as Croup. So parainfluenza virus type 2 is the major reason for Croup disease. So because it causes Croup, acute laryngotracheobronchitis kind of infection, this type of virus, parainfluenza virus type 2, is also known as CA virus. Yeah, so it can grow in monkey kidney cell cultures producing syncytial cytopathic effects. So they do show cytopathic effects on monkey kidney cell lines, and which is quite antigenically similar with the simian viruses. It won't show much similarity with the human viral infections, but it can cause serious infections, especially in young children, in immune suppressed or immune deficient individuals. Now, talking about parainfluenza virus type 3, this was also identified in children with a respiratory tract infection, and we used a heme adsorption to identify this type of virus. So parainfluenza virus type 3 is also known as heme adsorption virus type 1, HA1 virus, because we used heme adsorption process to identify this class of virus, and it has been identified to cause lower respiratory tract infections. So comparing with all the other three types, type 4 just shows mild infection, which was the latest addition to this list, which was identified in 1960, which can cause mild respiratory tract infections, which has got two antigenic subtypes, antigen antigenic type A and antigenic type B. Now, talking about the clinical presentations, all of them parainfluenza virus, they can cause almost respiratory tract infections, which happens around 10% of the individuals, young children, which requires hospitalization. The most serious clinical disease caused by this class of parainfluenza, this class of paramyxovirus is of course Croup, which is characterized by acute laryngotracheo bronchitis, inflammation of the larynx, inflammation of the bronchi, and which is more frequently due to type 1 and type 2. So type 1 and type 2 are the most common reasons for Croup kind of disease. Type 3 can also cause some lower respiratory infections like bronchitis, bronchiolitis, and even pneumonia, but not severe as type 1. So comparing the severity, type 1 is more dangerous, type 1 and 2 are more dangerous, type 3 is less severe comparing with the first two types, and type 4 shows mild infections. Parainfluenza viral infections are usually confined to the respiratory tract because they comes under paramyxovirus. They have a pre-affinity towards mucin receptors or mucosal membrane of human body. So they are primarily causing respiratory tract infections. Sorry. So let's learn about the lab diagnosis of parainfluenza virus. So since it causes respiratory tract infection, so the best samples for lab diagnosis include throat and nasal swabs. Throat and nasal swabs are the best samples for lab diagnosis. We can go for isolation of virus from these samples, where we will directly introduce this throat and nasal swabs into primary kidney cell lines. Primary kidney cell lines are used, and cytopathic changes will not be readily apparent because they won't show much serious or much visible cytopathic effects. Of course, we have to go for microscopic examination by immunofluorescence or by hematsorption techniques, hematsorption inhibition, hemagglutination inhibition techniques, to characterize and categorize them into the 4 types of parainfluenza virus. Of course, comparing with the virus isolation or cultural techniques, the most important and the most prominent one will be the serological examination. Where we will take paired sera, and we look for the presence of specific antigens or antibody, going for by identifying these antigens or antibodies can be identified by ELISA, hemagglutination inhibition, or complement fixation test, or rise in antibody titers in paired serum sample. And we have the most sophisticated and advanced methods available called PCR. It is a molecular diagnostic method using reverse transcriptase PCR, because it's an RNA virus. So it's all the Paramyxoviruses are RNA virus. So we have to use reverse transcriptase PCR to diagnose this clinical presentation. The next important paramyxovirus, which comes under this subfamily pneumovirus, is respiratory syncytial virus. You can easily make out the clinical presentation from the name itself. So this is something which is affecting the respiratory tract, and it can cause syncytial formation, multinucleated giant cell formation, especially in the respiratory tract, and this can definitely bring down the normal activities of those cells, and that can lead to severe lower respiratory tract infection. This respiratory tract infection or respiratory tract virus, the RSV, or in short form RSV, was first isolated in chimpanzees with coryza, and that was called earlier called chimpanzee coryza agent, or CCA. That is a respiratory tract infection in chimpanzees. And later we identify that they have a specific cytopathic effect. They can cause severe cell fusion and formation of multinucleated giant syncytial cells when we grow them in lab condition. And since it is causing infections in the respiratory tract, this type of virus has been renamed as respiratory syncytial virus, or RSV. And it is now recognized as the most important agent for lower respiratory tract infections, especially in infants, particularly in the first few months of their life. So they are highly susceptible for lower respiratory tract infection. I'm talking about infants in the first early few months of their life. They are highly susceptible to get this lower respiratory tract infection caused by respiratory syncytial virus. And talking about the morphology, they follow the normal morphological features of paramyxovirus, and they show some kind of pleomorphism with change in size. It ranges from 150 to 300 nanometer. And their viral envelope has got 2 glycoproteins, same like other paramyxovirus, G protein, which is required for the initial adsorption process, and the fusion protein, which is required for the fusion between viral and the host cell membrane. And this fusion protein is highly developed in respiratory syncytial virus, and by which it can cause syncytia formations by combining the adjacent plasma membranes of adjacent cells, right? And despite the fact that they belongs to paramyxovirus, RSV, respiratory syncytial virus, shows some mild differences or variations from other paramyxovirus. That they don't show any hemagglutination activity. They have heme adsorption activity, but they won't show hemagglutination or hemagglutination activity. It does not have a neuraminidase activity also, or hemolytic activity, because their primary mode of action will be the formation of respiratory syncytial formation. And they won't grow in egg containing media, but can be grown in human cell cultures like HeLa cells and Hep2 cell lines. it is antigenically almost stable comparing with other paramyxovirus. They won't show much variations in comparing with other paramyxovirus. Their antigenicity is quite stable. So, like I said, they causes serious infections in infants in their early stage of their life between 6 weeks to 6 months time, and most of the infections are RSV infections are symptomatic. The virus is hardly ever found in healthy person. It's absolutely depend on the immune status of the individual, and in the infection can cause broad range of respiratory illness, starting from febrile rhinorrhea with the cough and wheezing, progressing to lower respiratory tract involvement. There will be tracheobronchitis, and it can even develop to bronchitis and otitis media conditions. Mortality rate is really high in children with underlying cardiac defects and immunodeficiency. Definitely in young infants, their immune system is in the development stage, so this can bring some serious complications among them. And this respiratory syncytial virus is also considered responsible for about half of the cases of bronchiolitis and half of the pneumonia cases, especially in infants in their first few months of life. And most of the patients will recover in 1 to 2 weeks, but those with immunodeficiency or cardiac defects may have serious complications. And RSV is an important cause of otitis media, just like I said, in young children it can also cause otitis media, and in adults RSV infection may present as a febrile common cold. It's a common cold in adult conditions. It can also cause pneumonia conditions in elderly cases, right? Talking about the lab diagnosis, same like the previous one which we discussed, parainfluenza viruses. Here also the best sample will be the nasopharyngeal swabs or nasal washings. We can identify the presence of virus by growing the sample in specific cell culture media like human cell lines like HeLa and Hep2 cell lines, and respirate, because we will look for the formation of syncytial formation, cytopathic effects, and early detection of viral growth in the cells can be possible, and we can identify them by immunofluorescent test. And we also have some rapid serological tests which demonstrate the increase in antibody titers in paired serum samples. We can go for ELISA, complement fixation, neutralization, or immunofluorescent test. Of course, we have got molecular diagnosis by reverse transcriptase PCR, which is really sensitive to identify respiratory syncytial viral infection. Now, talking about the prophylaxis, we don't have any specific vaccination available for respiratory syncytial virus. Attempts of immunization and the studies have been started when we were actually unsuccessful in identifying a specific vaccine for this kind of infection. And talking about the treatment options, management is primarily by giving supportive antiviral therapy. That is, ribavirin is usually a drug of choice, and but continuous aeration should be given to those patients who are hospitalized, and that's how, and we can also provide some specific safety needs to prevent the transmission of infection from one individual to another. That's how we can tackle this clinical presentation.